Okay, it's 12:02, so we're going to go ahead and get started. Thanks again, everybody, for coming. We're truly happy to have you here today. We really try to do these for our alumni, as we all know that you have to have these continuing education credits for your career. So we want to try to make it as easy as possible and have some interesting topics. That's why we've brought in Lori Catalano, one of our fantastic faculty and staff members here at the College of Nursing. Just a little bit about Dr. Catalano. Her focus is on medical surgery, progressive care, nursing law, and ethics. Her research focuses on patient-centered care, specifically early interventions to improve rates of advanced care planning in patients with a heart failure. She's been a teacher for over 10 years now. Lori is just a really great fact, and she's done this presentation or a version of this presentation multiple times for us. So we're really happy to have her here today. And if you have any questions at all, please put that in the chat. And just so everyone knows, we are recording this presentation just to make everyone aware and make sure we're all on the same page. So if there are any questions, I'll make sure those get to Dr. Catalano. And Lori, the floor is all yours. Thank you so much.
All right, welcome everybody. I am, as he was saying, as Gage was saying, I've been faculty here at the College of Nursing for over 10 years. I think I just hit the 12-year point actually. So, but in my history includes the fact that I also went to law school, and while I am not an actively practicing attorney, I did practice for a while before I went back into nursing. So I am going to talk today about nursing after redonda vot. So I'm going to share my screen here. And okay. So one of the big things with nursing has always been patient safety, right? And I think that, we drill into our students starting their sophomore year of nursing school, a lot of medication safety pieces. And so but we also know that mistakes do happen, and we all live in the real world, and we know that nurses are human as well. And so I'm going to talk a little bit about what happened. And for those of you who followed it, I followed it, and there were actually some things that I learned later on that I was not aware of. So I'm going to talk about what happened, and then I'm going to talk about, real world situations, and then what we can do to protect ourselves. All right. So what happened? We know that everybody knows that she gave vercuronium, which is a paralytic, instead of Versed. And the entire story there is that she had floated to a unit, and the patient was actually getting a PET scan and needed to have some sedation. The patient was actually originally admitted with a subdural hematoma, but was ready to be discharged. Actually, she was supposed to be discharged, I believe, the next day, if I'm not mistaken. And so this was not a patient who was, in a medically induced coma in the ICU or something like that, but she did need some sedation for the PET scan. And so Ms. Vaught actually came in, and instead of withdrawing Versed, she withdrew vercuronium. So yes, they start with the same three last letters, or first three letters, but it wasn't just that. So when she went into the Pyxis, or whatever the machine was at the time, the patient wasn't in there, first of all. And so she had to override that. And then the patient's medication list obviously wasn't in there if the patient wasn't in there. And so she had to do everything via an override. Now, overrides, we are taught, are a once in a while thing, right? They're emergency situations only. At Vanderbilt, that was not the case. overrides were there. They were a thing. They were a very common situation there because they were having issues with their patient records, their actual charts speaking to the medication system. And so nurses were used to having to override almost everything for these patients. So now the problem is we also, and as we all know, when we're giving medications, we do kind of get complacent, right? It's the routine. We don't have to, when you give patients all the time, we get into a habit. And unfortunately, the habit there was that it included overriding all of the medications. So not only did we have our personal level of complacency with, the way we double check our meds, but there was also a complacency with overriding because it was.
I know. He'll stop soon.
Can you mute whoever that is, please? The other piece of it is, was there stress on Miss Vaught at the time? She was working in a unit that she hadn't been in before. However, she had been at the hospital for a few years. And so that wasn't one of the pieces that was really talked about a lot. Okay. The thing is, when she did do the medication, when she did give the medication, she missed a lot of red flags. Okay. And while I don't personally teach medication administration, we all know that we have our 5 rights, right? But I think we're up to like 8 or 9 now. The 5+2, I think, is the standard. So while she did indeed have the right patient, she did not have the right medication. And there were several triggers that she missed. And that was the big thing. They charged her originally with reckless homicide, but the jury found her guilty of negligent homicide. So that was that was what happened. But she missed a lot of things. So the label, obviously, of the drug said Vercuronium instead of Versed. Okay, so Versed is a brand name. Vercuronium is a generic name, and things are in the Pyxis under the other generic names. So when you look at a vial of Vercuronium, it says across the top, paralytic agent. And some of the things that she would have had to do, because she did have to reconstitute it, Versed does not have to be reconstituted. So that was another piece of it there. When you look at the vial of Vercuronium, the instructions for reconstitution are actually right under the name of the medication. And it also says in really big letters, paralytic agent. So she missed all of that when she was giving the medication. So that's what happened. Once they figured out that the patient was not breathing, she realized what she had done. And then the nurse who was with the patient at the time said, "I'm so sorry." Meaning that they knew she had made the mistake, that had ended up with that. But then nothing happened. So Vanderbilt did not report it. There actually nothing happened for several months. And then they received an anonymous tip about the mistake. So nobody knows who actually made the anonymous report. She did not lose her license at the time because it did not rise to the level of violating the statute. Now we all know what happened afterwards. She was charged, and then she was found guilty. So a little bit about the background of the Tennessee statutes. So Tennessee actually has a statute that, and I'm sure most of us here are in Ohio, but they actually have a statute that allows you to be charged with criminally negligent homicide without specifying what the route of death is, or what the cause was. So negligent is different. Negligence is different from homicide. Negligence means a reasonable nurse in a similar situation would have appreciated or foreseen the risk for the patient. Now, if we look back at our 5 rights that we're all supposed to go through when we're giving a medication, Redondavat was definitely negligent. Okay, from a legal perspective, she was definitely negligent. And this may not be a popular opinion, but I also think as a nurse, I also think she was negligent. Okay. This doesn't mean that I agree with the outcome at the end, but I do agree that she was negligent. Now, what she was charged with was recklessness. And recklessness means that the person being charged has to actually appreciate the risk. So they have to know the risk. Negligence is different. You don't have to be aware that what you are doing is dangerous. Okay. And so that's the big difference there. The jury did not feel that Redondavat knew what she was doing. Okay. They didn't think she knew that she was injecting vercuronium and not Versed. Which by all accounts, I believe her. She, for all of the other reasons, complacency and the stress of a shift and things like that, she didn't know. But she missed a lot of triggers that would have made her realize that. So that's the difference between recklessness and negligence. Now, in Ohio, negligent homicide has to happen with a car or a weapon. So this case would never rise to that level in Ohio. Simply because of the way our negligent homicide statute is worded. So that is you can't charge them with something. It specifies that it has to be a dangerous ordinance, which is a weapon, okay, like a gun or something, or a bomb, okay. Things that would be negligent homicide in Ohio they would not include nursing malpractice, okay, or medical malpractice for that reason. In Tennessee, though, their negligent homicide statute is a little bit more broad, and it does allow for any type of negligence, not just something that involves a weapon. Okay. Now, Ohio does have a reckless homicide statute as well, but again, her actions did not rise to the level of recklessness. There was no, everything that I've read it didn't show that she was aware of that. All right. So what do we know about medication errors? Because this is the basis, right? And a long time ago, in 2010, we had the report that was issued that said with all the medication errors that we have, and it was it's called To Err Is Human. And what we found in that report was that 41% of Americans are involved with a medical error, either personally or secondhand, meaning that one of their relatives. Okay. That's a lot. That is a lot of people. And so we started instituting all of those safeguards that we have, right? The barcode scanning on every medication, the barcodes on every patient, and nothing helped. When we look at our med errors now, they're really not significantly less. And we know that a lot of our med errors are made because of system issues. And I already talked about some of the system issues that Redondavat suffered, including the patients not being loaded in the medication cabinet. Their charts aren't speaking to it. So every single med was an override. That's extremely dangerous because it loses that one double check that we have. Okay. So there are a lot of things that we can prevent. And we have made significant strides in that, but the system has to work. And that's where I say, yes, she was absolutely negligent. However, there were a lot of system issues going on right there. And I think one of the big issues there was that it appeared that Vanderbilt was covering it up. And I don't want to, because I'm not as familiar with the internal side of Vanderbilt, I don't want to say, yeah, this was a deliberate cover up. I don't want to accuse them of that. I think that it definitely could have been handled a lot better than it was by Vanderbilt. And the nurses at Vanderbilt definitely agree. We all saw on the news where the nurses were quitting and they wouldn't, they wouldn't come in for their shifts and things. So, but the problem with the case is that we have a culture in nursing that says that individual errors should not be, individual errors are usually system issues, right? And individual practitioners should not be held accountable for system issues when you don't have any control over it. Every nurse at Vanderbilt had to deal with the system issues, right? Where the patients were where the patient's medical record was not speaking to the medication system. They weren't there to, with a medication list to pick from. Their MARs weren't speaking to that. And there's, just culture says that our individual practitioners, our nurses shouldn't be held accountable for stuff like that. And that's just fair, right? And we have to address those system issues. That's the whole point of it. So when we are looking at the system issues, the fact that they needed to override, and how often did they have to override? From what the other nurses were saying, they had to override with almost all the time. Because their medication, their charts just simply didn't talk to the med system, right? Whether it was a Pyxis or something else, their charts didn't talk to it. And so none of the patient information was in there. Now, we all know that we do have emergency medication overrides, and there are certain medications that have to be able to be overridden as an emergency, right, for every patient. I have a cardiac background, and we would override things that were rescue drugs. Okay. So we could override without actually breaking open a crash cart, we could still override, cardiac medications. And that's different from a paralytic. Okay. Now, is there a time where you might need to override a paralytic? Absolutely. In an ICU, you may need to do that. However, it's not, there were way too many things that they were having to override. Okay. And the other piece is understaffing. This was, I know that we're all understaffed with COVID right now, but nursing has always had a shortage. Nurses are always understaffed. The nurses that spoke at the trial said that Vanderbilt was understaffed at the time. So nurses were getting floated to units where they didn't necessarily work. Nurses were taking more patients than they usually had. It was a real thing. This was prior to COVID. So I don't know what the staffing situation was that particular day that led to her being floated. However, in the trial, it was stated several times that the nurses at Vanderbilt were understaffed at the time. The other big issue here is the increased stress levels that we have with our with understaffing, anything with the system issues. Can somebody mute, please? Can everybody just make sure that they're muted? Thank you. So when you're understaffed, when you have these system issues, every nurse is under a lot of stress as it is, right? And so when we have these extra system issues on top of it that aren't being addressed, apparently these were a long time coming. All of these issues had been going on for a while. This wasn't, oh, the computers are suddenly down today. It wasn't a situation like that. And so that puts even more stress on the nurses. And we all know that stress impacts our ability to think clearly, right? So anytime you're under more stress, your ability to follow all of the safeguards that we have in place is going to change. But She didn't follow all the medication rights. So we've got 5 med rights, the standard ones, right patient, right drug, right route, right time, right dose. The +2 is right reason and right documentation. And then we've added three more on top of that, which makes 10. The patient has the right to refuse, you do the right assessment, and you do the right evaluation. So what did she do wrong here? Obviously, wrong drug. And that was one of the original medication rights. And there were so many things that, there were so many times when she could have caught herself here. And that's one of the big reasons why I say, yeah, she was negligent. That is a huge deal to skip, to make a mistake like that. When there are so many triggers, there's so many instances, so many red flags that she ignored. And that was one of the big pieces of the prosecutor's case, was that she had ignored, they said at least 10 things that she ignored. I personally could only come up with 5 when I looked at it. I felt that they were pushing it. But the cap says paralytic. The side of the vial says paralytic. Right underneath the reconstitution instructions, it says paralytic. The name of the med is right there next to the reconstitution instructions. So I could only find 5 things that I really felt should have triggered her to say, oh, this is the wrong medication. But regardless, she did get through. There were several red flags that I think should have stopped her. And even if one didn't, the next one should have, or the next one, or the next one, or the next one. So that's my personal opinion, that she was indeed negligent. So let's talk about shortcuts. We all take shortcuts, and she took a shortcut because she overrode the medication. Now, I don't know that I would really call it a shortcut when it was the standard practice at Vanderbilt at the time, was to override all of these medications because of the system issues that they had. But when we are taking a shortcut, when we've got a medication to give, we all know that it takes a little bit of time for pharmacy to get things entered into the computer when an order comes in, and or get things checked off down there. And do you override the medication, or do you wait for pharmacy? When you're in a situation where she has a patient undergoing a testing procedure, okay, and her she needs to give this medication. The testing department wants her to be sedated so that she can have this procedure or this scan done. And that there's other patients waiting behind her. Do you wait for somebody to fix the error? Even if this were a situation where it was just a matter of time, and not a big system issue, we all know that we override, right? Because we've all got so many things to do during our shifts. So, and we have a lot of shortcuts. And, it's interesting because I teach my students shortcuts are okay to an extent if they're still safe and if you know the rationale behind them. I'm not going to teach you the shortcuts. I'm going to make you learn everything the full, complete way. And then you can learn the shortcuts on your own while still maintaining all of the integrity of whatever it was that you're doing. One of the examples that I give to students is, when we teach students how to do a dressing change, for example, we give them a little sterile bowl, and they pour their saline into the sterile bowl. And I don't know about any of you, but when I do a dressing change, my wrapper for the dressing is my sterile bowl. And it doesn't mean that it's not a sterile dressing change. Doesn't mean that I'm doing anything wrong. It's just shortcuts that we've learned. Okay. And so I don't know that I would really call her actions a shortcut because she was forced to do it that way. She was absolutely forced to do it that way. But in the end, what does it mean? So what does it mean in Tennessee? What does it mean in Ohio? In Tennessee, it means that a nurse who is who has a negligent action, so is definitely negligent by definition, because a reasonable nurse would not have done what he or she did. And if that negligence results in the death of someone, that nurse can now be charged. That is what that means in Tennessee. That is going to be the precedent in Tennessee. Absolutely. Now, what does it mean in other states? That's going to depend on the statute. So like I said, with Ohio's negligent homicide statute requires you to have a car or a firearm or a bomb. So it has to be a dangerous ordinance, basically. And so that's not part of nursing. Okay. And so negligent nursing acts would not be able to be the basis of a negligent homicide charge in Ohio. Now, I did not look up every state. I did look up several of the surrounding states, though, and several of the big states. And there are very few states that actually allow for a negligent homicide charge that doesn't involve a gun or a car. So some examples would be if you're texting while driving, that may rise to the level of recklessness, but if you have a car wreck because of your negligence and you kill someone, that could be negligent homicide. If you take a gun and you are not really paying attention, and you accidentally kill somebody while like hunting or something, that could be negligent homicide. If you take a gun and you fire it into a crowd of people, that's no longer negligent, because you should definitely know, that you're taking a risk there. But it still has to have a firearm in Ohio. So Ohio nurses are safe from this negligent homicide charge. But there were a lot of people who saw the slippery slope. Okay. So some of the position statements, and I don't know if anybody has read them, but I really like the American Nurses Association. So what they said, I'm not going to read it all to you, but they said that healthcare delivery is highly complex, and it is inevitable that mistakes will happen and systems will fail, and it's unrealistic to think otherwise. And they pointed out that there's more effective mechanisms to look at these errors and to establish system improvements and take corrective action, which we've been doing all along. We've been doing with the just culture, where we say there's got to be a system issue here. And then, the ANA looked ahead and said the nursing profession is already extremely short-staffed and strained, and facing immense pressure. And we all know that this didn't start with the pandemic, right? The short staffing and the pressure that has been on nurses for years, it didn't start with the pandemic. It was exacerbated by the pandemic. And the ANA they saw that this could have a lot of long acting effects. Okay. And they did say that they were deeply distressed by that verdict. AACN and a couple of the other, and the American Hospital Association noted that it was a sad day for all of those who were involved, and noted that decades of safety research demonstrated that a punitive approach to healthcare errors drives problems into the shadows. And that is what I feel is the big issue here, is that our mistakes, our errors are not going to be reported anymore. And so overall, I do agree with this statement here that the case has placed patient safety at risk. And that was something that the AACN did say, and that's the American Association of Critical Care Nurses. They said that this case is placing patient safety at risk, because what happens now is that a nurse who makes a mistake is going to be afraid to report it, because he or she will be afraid of prosecution. So that's what I see as happening. And from what I hear, it's already happening. Nurses are already afraid to report things. They said it further demoralized an already exhausted and overworked nursing workforce. This happened 4 years ago. And the case just, this is just the end result. It takes a long time. I mean, it took a long time for her to be charged. For us nurses who have worked through the pandemic, these last almost 3 years now, nurses are exhausted. You guys all know that. Nurses are exhausted. And this was just one more thing, right? And then they noted that it has a chilling effect on the culture of safety in healthcare. That just culture, it's not going to exist anymore. That just culture has completely been overridden by this case. The verdict is harmful to nurses and all medical professionals. That was the Institute for Healthcare Improvement noted that the verdict, it's not just nurses. All medical professionals should be afraid now, because while this was a nurse, negligence is negligence. And if you are a physician and you commit medical malpractice, now you are, and your patient dies, now you are up for a homicide charge, at least in Tennessee. And so this case should be on the forefront of physicians, pharmacists, anybody who has the ability to negligently cause the death of a patient. This should be on their minds. Ms. Vought's arrest and conviction makes patients less safe. It doesn't make them any more safe to do this. And patient safety has always been the goal of all of our nursing boards, the medical boards as well. And all of nursing in general has always been focused on patient safety, and this is going the wrong way. So I personally think that we have a slippery slope here. I think that we are going to have a very huge impact on the reporting of errors. I think nurses are going to be very reluctant to report errors. And if you can imagine, if you negligently did something that caused the death of a patient. So think about a medication error that you made, because we have all made a med error. I am very open with my students about medication errors that I have made that I know of. And remember that you've probably made some that you didn't know of. But we've all made errors. Now imagine if that error led to the death of a patient. What would you do? Would you report it? Would you report your med error? Because that's exactly the problem here, is that I don't think they're going to be reported. I don't think even the simpler med errors are going to be reported. And so I think that this case represents a really slippery slope for reporting things. I also think that this is huge that a nurse was charged, and we are lowering the bar for criminal charges now. So Tennessee wanted to say that it was reckless, that she knew the risks and chose to do them anyway. That's what recklessness means. And I'm worried that what was truly a negligent act by every legal person who's written about the case has said, yeah, this was negligence. It was not recklessness, and the jury agreed it was negligence. But I feel that we're lowering the bar for criminal charges, and I hope it doesn't happen. But I feel like this is indeed, we are at the top of the slippery slope here to go down there. So what can you do? And these are obviously follow your 5 rights. But some of the things that I've been asked is, how can I protect myself? Get malpractice insurance. That's a big deal. When I was a nurse, practicing nurse, now I teach, I mean, I know that's still being a nurse, but when I was practicing at the bedside, I did not have malpractice insurance. And looking back, I should have. I think everybody should have it, because while it is true that if you are following policy and procedure, you are covered by your hospital's insurance, okay, by your hospital's malpractice insurance. Their goal is to protect them, okay? The hospital's insurance policy, the hospital's attorneys, their goal is to protect them. If you're ever charged with something, you need to get your own attorney, okay? And that malpractice insurance will pay those legal fees, okay? It also takes care of fines if you ever were to get fined for something. But even if it doesn't rise to the level of a trial, you are still, you can still have an attorney with the Board of Nursing. Any hearings that you have with the Board of Nursing, you are allowed to have an attorney present. I highly encourage you to have an attorney present. So I had the opportunity to talk with a defense attorney about malpractice insurance. And she actually was giving a presentation with the hospital council. And they were talking about malpractice insurance and what is actually covered by malpractice or by the hospital policy. A very small act of negligence that harms a patient that is malpractice will most likely be covered because it is negligence. But that hasn't really been tested that much, which is why I say get your own, because as soon as you do something that's negligent, you're outside of the hospital's policy right there, because you're not following it. And so at that point, I think that there could be a good argument by the hospital insurance company that you're not covered. All right, so reporting errors. Do we still report them? Yes. We have to report the errors still. We absolutely have to report the errors. We have to address, that's the only way to identify system issues, is if nurses report the errors. And if we don't ever know about them, they're never going to be addressed. Okay. And then once we find the system issues, address them. That was the whole situation here, where there were system issues that were never addressed. Could the nurses do anything about it? Having been a staff nurse, I don't know that I could have done anything about it. Looking at the outside, yeah, they could have really caused an uproar about it, but I don't know. I don't know if they, realistically, if they could have done anything about it when the administration at Vanderbilt knew that there were system issues. Be extra careful when the same situation happens to you. And I don't mean making a mistake necessarily, but anytime you are in this exact same situation where you're overriding a medication, be extra careful, because you've lost some of those safety checks that we have in place. And I think it's super important that we go back to nursing school and we look at those 5 rights and we say, okay, I'm going to check all this. I know that not all of you in the room will remember this, but I remember when we still had handwritten MARs and we had to check them against the order, and nothing was, it wasn't computerized. We didn't have, all of those system checks that we do now. And so, when those computers went down, that was a big deal. And that is a big deal for people who are new nurses who haven't ever known anything else. And so I end you with the thought that it could have been me, it could have been you, it could have been, and so we have to make sure that we really do go back to those safety checks that we all learned, but we all got kind of complacent about. All right, so what questions? Amy, nurses with agencies and compact license will need to know the laws in the states where they work. Yes, and that's a change as of January 1st with the compact licensure. Unfortunately, it's true. It's not where your license is, it's where you're working. And so I'm actually not sure if Tennessee is a compact state. I know that Kentucky is, and Ohio is now a compact state. I actually have a Kentucky compact license because I live in Kentucky. And I also have an Ohio license, in which I don't need anymore. But there are a lot of compact states. I want to say it's over 35 at this point, probably closer to 40 that are states in the compact. And so I really worry about our travel nurses, people who are traveling, who are working for agencies, because they have to know the state law. Because they have to follow that State Nurse Practice Act. Absolutely. All right. Any other questions?
There was one actually that I had that was directly to me, and it's just clarification, I guess. Can you clarify that a nurse in Ohio couldn't be charged with criminal negligence? Or can
so
just
negligent homicide in Ohio requires you to have negligently fired a firearm. So nursing malpractice cannot be the basis of negligent homicide in Ohio. No. Unless they change the statute. They could change the law, but right now, no, that is not what the law in Ohio says.
Thank you. I didn't have any other questions that were sent to me. So if there's any other questions that anyone has for Dr. Catalano, that would be the time is now.
I have a question on if Vanderbilt has made any practice changes. Are we aware of that? Because obviously this is a very deep-rooted problem with their facility and the overrides. So has there been anything done as far as them saying we're making our hospital and our patients and our staff safer at this point?
It's interesting because if from what I've heard, now Vanderbilt is obviously not advertising any changes that they're making. What I have heard through just nurses talking is that there has not been a lot of practice change, which is why I don't know if a few months ago you were watching, Vanderbilt nurses were quitting right and left. And there were people who would actually accept a position at Vanderbilt and then not show up on purpose. So that's an interesting piece. And I don't think that Vanderbilt has made any huge changes here, which is why, again, I'm like, I don't want to say they were covering it up, but there were definitely a lot of system issues that they never reported. So, Flora, yes, it's a very disturbing response from them. Absolutely. If the same trial was held in Ohio, what would have been the verdict? I don't think she would have ever been charged in Ohio because the statute didn't speak to her actions. So the law in Ohio is very specific as to what rises to criminally negligent homicide. And like I said, it would have had to have been a gun. We don't use guns in the course of our nursing care. So now if she was charged with reckless homicide, your reckless homicide in Ohio, if her actions were reckless, however, that recklessness versus negligence, I personally think it was negligence. That's for a jury to decide. Recklessness means that you have to know that what you're doing is risky. And the jury agreed that she just never saw the warnings. She was so complacent that she never saw the warnings. So if they didn't register in her brain. So, telehealth, is it correct? You have to have a license for every state you call have a license for every state you call in another state. Telehealth laws are different. If you have a compact license, that takes care of the telehealth, but I know that telehealth laws have changed with COVID. And so there are, there's less of a mandate that you be licensed in both the state you're in and the state that the patient is in, simply because of COVID. Things were getting changed, but it would have to be, you'd have to look at your specific, at the specific state to see. So Amy notes that the nurses can get involved in clinical ladder to change practice. I agree. There are a lot of ways, but then, realistically, I don't know that, and I don't know what the nurses at Vanderbilt had tried already. Clearly, if they had tried anything, it wasn't working because Vanderbilt wasn't changing. So looks like somebody has their hand up also.
Hi, Lori. This is Beth Willing. I worked with you back in the days when we had paper.
Yes.
So do you think that this is, and I know that the nurses at the bedside are extremely stressed and overwhelmed and short-staffed, but do you think that this is the importance of trying to fill out incident reports for near misses? And I just wonder that although the nurses were very aware up the chain with the risk management, how aware were they of all of these problems? Because sometimes there can be such a big disconnect between what's known and the managers maybe not communicating that effectively or not wanting to, but like incident reports for near misses, I wonder if that's something that we should stress with our students, although it's hard when they've got everything else they have to do. So I just wanted your opinion on that.
Yeah, I think that the incident reports for near misses are a huge thing to help identify system errors too, because there's going to be so many more near misses than there are actual med errors. And that's because of all of our double checks that we are taught to do. And I think that, in this case, had she caught one of those times, would that have been a situation where it would have been an incident report for a near miss? Yeah, absolutely, if she had caught it. But then I look at how overworked everybody is right now, and to catch something and say, oh my gosh, the wrong medication is in here. Okay, well, I didn't give it, and I've got 13 other things that I have to do yesterday. I don't have time to do an incident report for a near miss. And unfortunately, I think that is a big, I think that's going to be a big deterrent, is just the time to do those things. I mean, everybody knows you have to fill one out for an actual error, although I do think the number is going to go down after this case. I absolutely think people are going to report less. But for near misses, I think we're going to see I think we probably already have seen a tremendous drop off, because it's just one more thing on our list of stuff to do.
Well, yeah, because the systems aren't easy for the bedside nurse to navigate. They're not simple at all. And it puts the onus totally on the bedside nurse to do it all, because not only they fill out the near miss, then they have to call pharmacy and they have to do all the things. It's just a big expectation. But I also think that that's why some of these system issues don't get captured, and then something horrible happens like this.
Right, absolutely. And we can report to our manager, say, hey, pharmacy did this, that did happen to me, and I'm not picking on pharmacy, where the wrong medication was actually loaded into the Pyxis. When I went to pull it out, I went to give it, and I was like, wait, that's not what that is. And I knew, and only one thing popped up, only one little drawer popped open. So that is what it was supposed to do. Did I call pharmacy? Yeah. Did they replace it? Yeah. Did I fill out a report? I don't think I did, because I had too many other things to do, right? And that just wasn't on the, you have to do this as soon as possible thing. You know, did I tell my manager? Yeah. Did it go anywhere? I don't know. So those are, you know, those are things that, oh, Tennessee. Oh, okay, good. So Tennessee. All right, criminal. Okay, that is, okay. So, Tennessee is a compact state. So there you go. And, so Keely, that's involuntary manslaughter. That's different. So yes, you can get charged with involuntary manslaughter for criminal neglect of a patient. Yeah. Yeah, that's it. And I don't know if everybody knows the difference here. I know you've got experience, Keely, but, so involuntary manslaughter is different. You can get charged with involuntary manslaughter. This was homicide. Okay. And that was the big deal. That was the big deal. So there have been people, and this headline, patient rotted to death. That's terrible. There have been cases where patients have been neglected. They are usually nursing home cases, where patients have been neglected for so long that they have died. And that is a manslaughter charge. Absolutely. So manslaughter charges it's not quite the same. A lot of those are, you know, for a homicide charge, most homicide convictions will result in jail time. Manslaughter, not necessarily. Any other questions? Luann commented that it's always going to be a big issue. Staff just don't want to complete the form. It's terrible. It takes at least 15 or 20 minutes to fill out one of those MIDAS reports, for, you know, you know, for whatever system you have, whether it's the MIDAS system or whatever, to report an error or a near miss, it takes forever. You know, and I mean, I can joke it. I can remember joking around with nurses that I worked with saying, we don't want that patient to fall. We don't have time to fill out that report, you know, because it takes forever. And if you think about all of the things that you have to do on your shift, it's just one more thing. So.
Any other questions? Oh, looks like there's a. Thank you for providing this critical information. Yes, of course. Thank you, Lori, for, you know, taking this valuable time out of your schedule to present this information to everyone. We truly appreciate it. Seeing no other questions, thank you everyone for their time. I will follow up in about probably 5 to 10 business days with your certificate. Please don't reach out to Lori. It will be me you need to reach out to. For that. So if, you know, please, if you do have questions for Lori though, I will include her contact information in that, and in the email.
I can't give legal advice. None of this was legal advice.
Yes.
My professional nursing advice is go get malpractice insurance.
Yeah. So if you do have questions though that aren't legal questions for her, her email was actually in the registration link email that was sent yesterday. So you can directly reach out that way, and then I will also include it in the certificate email. So thanks.